Good afternoon, everyone. I'm John from HTN, and welcome to this webinar today, where we are joined by a panel of experts in surgical site infection care for an insightful discussion on how digital innovation is reshaping clinical practice and improving patient outcomes in this area. So I'm really pleased to welcome a panel joining us today. We welcome Melissa Roshan, the Trust Lead for SSI Surveillance Research and Innovation at Guy's and St Thomas NHS Foundation Trust, Kenneth McLean, the Innovation Lead at the Association of Surgeons in Training, Ishtaq Ahmed, a cardiac surgeon at University Hospital Sussex NHS Foundation Trust, and Pete Hansel, the CEO and co-founder of Isla Health. So thank you to the panel for joining us today. So for this webinar, we are here to explore one of the most pressing challenges in surgical care, surgical site infections, and how digital innovation is transforming the way we prevent, monitor, and manage those. So this session will share practical examples of how digital pathways, automation, and workflows are improving clinical efficiency and helping drive better outcomes. So the structure of the webinar, we will hear from our panel in terms of their experiences and their work in this area, and then we'll go on to a Q&A. So this is your opportunity in the audience to ask any questions that you have for our panel. So to do that, please type any questions into the chat and we'll keep an eye on those as we go. But like I say, we have a planned 25 minutes for a Q&A as well. So I'm keen to hear your questions. And then we'll move on to some key takeaways and close the session. The session is being recorded and there'll be a write-up done by the HTN team that will be shared afterwards, so you can read or watch it back at a later date and also share it with your colleagues. So that's it from me for the housekeeping. So let's get started. If I could ask the panel to introduce yourself and share how you've seen digital tools, particularly automation, change the way you approach, monitor, and prevent surgical site infections. So I'm keen to hear about your work in this area. So Melissa, we'll start with you. And we have a pre-recorded video for this one. So we will press play on that one.
I'd like to start by thanking today's organizers for the opportunity to join this panel. Surgical site infection surveillance or surgical wound monitoring is one of the most promising areas for digital transformation in healthcare. It's a great example of how technology and automation can unlock efficiencies and allow us to scale care in ways that simply weren't possible before. At Guy's and St Thomas's in London, we use Isla for surveillance in many different surgical specialisms, from breast and vascular surgery to cardiac, obstetrics, general surgery, thoracics, renal, and pediatrics. To date, we've already provided 20,000 surgical patients with remote wound monitoring using Isla. But the real shift, in my view, is not just scale. It's really how we're transforming how we deliver care. This technology takes us beyond simply preventing SSIs within our hospital walls where we have traditionally focused. It's creating a powerful opportunity really to directly involve patients in their own care, in their own home, to improve self-management, and I think really to reduce the risk of infection in the community setting. So this is a really important bit to me. The truth is we've been overlooking the fact that most SSIs show up after patients leave hospital, not because we don't care, but simply we didn't have the right systems or technology to tackle it properly until now. So why is this so important? SSIs are a major cause of harm after surgery. They contribute to over a third of postoperative deaths and lead to significant complications, including longer hospital stays, prolonged antibiotic use, emergency readmissions, additional surgeries, and poor long-term outcomes for patients. The NHS spends around £980 million each year managing surgical wounds, with almost half of that cost now falling on community services, not the hospitals, creating service pressures across the healthcare economy. Importantly, a large proportion of these infections are considered preventable. Surveillance plays a crucial evidence-based role in improving patient safety, but there's a major gap. According to Getting It Right First Time, fewer than 10% of hospitals they visited knew their own SSI rates. Why? Our research suggests that surveillance remains labor-intensive, costly, and outdated. For example, national surveillance frameworks were developed decades ago. Since then, hospital stays have shortened by around 40%, and this trend is set to continue as we've seen a rapid shift towards same-day surgery and enhanced recovery pathways. The result? Infections are often picked up after patients leave hospital. So while the hospital data may suggest falling SSI rates during inpatient stay, in reality, many infections are simply moving into the community and going unreported. In my opinion, SSI surveillance is where technology moves from beyond simply enabling processes. It becomes a true catalyst for transformation. By using patient-generated health data, including photos taken on smart devices, we can modernize outdated methods like phone calls or postal questionnaires, making the process far more efficient. But the change goes deeper than speed or really convenience. We're fundamentally shifting the model of patient-reported post-discharge surveillance from a retrospective data gathering exercise at 30 days that offers little direct benefit to the patient you're calling to a proactive patient-centered approach. Instead of asking patients to recall symptoms after the fact, we enable real-time check-ins that help detect complications early, support timely treatment, and provide more accurate, actionable infection trend data. So what does this look like in practice? I'll use our GSTT example of ILA in cardiac surgery for post-discharge surveillance. The ILA service supports approximately 2,700 cardiac patients each year across our 3 hospital sites. 75% of our cardiac SSIs are detected post-discharge. In our own practice, we've reduced patient-reported SSI rates by 35% since establishing our baseline data. We've decreased unplanned readmissions and reoperations, and we've also looked into healthcare resource use for patients with an SSI. Presented in the lower table, we're comparing healthcare resource use between national guest data and local data collected over a 6-month period. So starting with GP visits, nationally, 73% of cardiothoracic patients had a GP consultation associated with an SSI, while locally, this was significantly lower at just 35%. A similar trend is seen with practice nurse visits, 81% nationally, compared to 48% locally. Hospital outpatient attendance is another area of difference, with 86% at the national level versus only 3% locally. Finally, A&E visits were reported in 29% of the patients nationally with an SSI, but only 16% locally. Overall, we're seeing a consistent pattern. Patients with an SSI at our local sites are using healthcare services less frequently than the national average, which I think highlights the impact of ILA in our program. Even when the patient develops an SSI, there's still a benefit to the broader healthcare economy. And we're now pushing further to do more to prevent SSI in the community. This involves piloting resource kits for patients showing early signs of wound breakdowns, combining digital monitoring with self-care support. Using ILA, we're developing a targeted approach to sending resources to suit our suitable patients, such as items to cleanse the wound, as well as dressings. We're exploring outcomes, patient experience, and cost, but early results are really very promising. To me, this is what modern surveillance looks like: patient-centered, data-driven, and preventative. Our mission is really clear: a system-wide approach to digital wound surveillance with ILA for better patient care and outcomes. This is a new model for post-discharge surveillance, and I'd really like to hear your thoughts on this idea, and I'm looking forward to discussing further in the Q&A session. Thank you.
Fantastic. Thank you, Melissa, for setting the scene and providing context and great data as well. So thank you for sharing that with us. Right, we'll now go on to a wider introduction from Kenny.
Hi there, everyone. My name's Kenny McLean, a surgical trainee, postdoctoral clinical fellow at the University of Edinburgh, and innovation lead for the Association of Surgeons in Training. The recent Future of Surgery report from the Royal College of Surgeons of England highlighted that digital transformation, including integration of AI into clinical practice, is essential for delivery of healthcare in the future. To meet these future healthcare demands, there's been a huge shift in discussion from reactive to proactive healthcare, and SSI represents an important target of reducible postoperative morbidity. My team in Edinburgh completed the first full-scale randomised control trial for the impact of remote postoperative wound monitoring on surgical site infection, comparing this to routine care. We found we can diagnose these surgical site infections earlier, reduce healthcare usage, and improve patient experience. However, despite these many benefits, manually triaging the responses received poses a huge burden to already overstretched clinical teams. However, a huge strength of digital health interventions like remote post-operative wound monitoring is these can provide the opportunity to incorporate automated assessment. The challenge of applying this to surgical site infection lies in a complex and subjective criteria to clinically assess, involving integrating multiple types of data, aka multimodal data, such as symptoms, wound appearance, and so on. With advances in machine learning, we can leverage neural networks to use this multimodal data from the patient responses within the same model to allow real-time SSI prediction. We have built a proof of concept model using real-world data from our clinical studies, incorporating patient-reported symptoms shown there, as well as wound images to predict the probability of SSI. And this can also generate heat maps to show both clinicians and patients where the specific concern is. The value of this multimodal approach is that the combination together had an equivalent performance to clinician-led triage for predicting SSI within 48 hours of response. In our remote post-operative wound monitoring pathway, shown on the left, all responses are reviewed by clinicians who then give their clinical recommendations directly to patients. We simulated the impact of using our multimodal model in practice to rule out responses at low risk of surgical site infection, shown in the pathway on the right. In this scenario, all responses classified by the model at moderate or high risk were still reviewed by clinicians. This reduced the staff time required to triage by over 80%, while maintaining the diagnostic accuracy and the same low number of missed surgical site infections. Overall, we were able to demonstrate that automated assessment can be successfully deployed within remote postoperative wound monitoring pathways, allowing resources to be appropriately directed to those at greatest risk of surgical site infection. Yet as digital transformation of healthcare continues, we remain far off from a fully automated approach to diagnosis of SSI, with particular concerns around the clinical and legal implications of false positives and false negatives. We also need to ensure that everyone in society is benefiting equally from this. I'll finish with a thanks to all those involved in making this work possible, and for those interested to hear more about this in detail, this work has been recently published in Nature Digital Medicine. Thank you very much.
Excellent. Thank you for that, Kenny. And next we'll go to Ish for a wider introduction, please.
Hi, good morning, and thanks for inviting me to take part in this panel. I first want to just thank Peter and his team at Isla, who have been very helpful in helping us orchestrate use of digital platform at the Royal Sussex County Hospital where I work, and also to Melissa for all her support and continued enthusiasm to tackle surgical site infection. So my involvement as surgical infection lead in Brighton has been the adoption of the Isla platform over the last 3 years. We initially got a digital innovation grant, which helped us pilot this technology. So in terms of cardiac surgical patients, any kind of cardiac surgery has a big physical impact. Our patients are getting older, they have multiple morbidities, increasing incidence of diabetes, and multiple procedure cases, and by definition, they're going to be on the table longer. We know that those people who spend longer on our operating table have a bigger physiological impact, and other aspects of their post-operative care need that detailed management. And surgical site infection is one of those things that is, unfortunately, one of those complications that is prevalent to a small degree after having cardiac surgery, to about 2 to 5%. And so what we wanted to do is just to try and reduce the impact of that and manage that in an appropriate way. And I think before we had Isla, we didn't really have a good handle on the data. We didn't really have a good indices of the numbers that of surgical site infections that we had, either in hospital or after discharge. And also we wanted to have a platform where we could advise patients actionable points to be able to manage their wound at home and when to trigger coming into hospital or having antibiotics. And now that we have had Isla, we have a robust platform to collect that data. It has enabled us to empower one of our nursing staff to have a surgical site surveillance lead to be able to encapsulate all those patients who have actually left the hospital so that we can manage them. And it's enabled patients to empower them to actually look after their own wound. It's given them a contact within the hospital with specialists that understand post-op surgical complications so that they're not drifting in the community and having a wound that should be managed early. And it has enabled us to act quickly, whether that's highlighting this to GPs, highlighting the need for antibiotics, or arranging an early readmission. The feedback has been really excellent, and what we have found is that it's actually reduced some of the more serious complications that occur after having surgical site infection if we manage these issues very early on in the pathway.
Fantastic. Thank you, Ish, for that. And we'll move on to Pete. Over to you, Pete, for a wider introduction, please.
Thanks, John. Thanks, Ish. Very much reciprocated. It's been wonderful to work with you over the last 3 years. So yeah, good afternoon, everyone. Just to give a quick background on Isla and the business that we've created over the last 5 years. Melissa actually just reminded me when we started this webinar that nearly 5 years ago we did a webinar with Melissa and Kenny, which was right at the start of our journey and right at the start of kind of learning about the SSI space. So it's very good to see how far we've come collectively since then. So Isla is now a team of just over 50 people based in London. We're working quite broadly across the NHS and starting to work with the HC in Ireland as well, which is really excellent. We work with 30 organisations today, and we support over 40 different specialties. So broadly speaking, Isla can be deployed kind of into any specialty, and from there we select different pathways which we can help to transition to a much more scalable digital model. I also remember when we were very excited to have hit 10 submissions in a day, which is a bit of a milestone. That was probably about 4 years ago. We now receive over 2 million submissions annually. A submission is, for us, effectively when a patient is submitting data into the health system, which can facilitate a remote review. So in this case, a set of information which would normally contain the image of the wound and a patient completed assessment form so that we can understand coded data about that patient's condition as well. The thing that we're most proud of in terms of our impact for health systems is that we've been able to deliver both cash positive implementations, which means that trusts can continue to work with Isla for many years, but also huge patient impact, and in this case, particularly prevalent sort of patient safety impact. And then along the journey, we've been able to get the business B Corp certified as well, which is just a nice kind of recognition of, I suppose, the way that we like to do business and the very collaborative approach. Lou, if you just jump on slide, please. Thank you. So we at Isla, we talk about building the digital pathway platform. So I thought it'd be good just to kind of zoom out and contextualize that a little bit. So really what the change that we're trying to create for the health system is to move away from predominantly collecting information from patients by seeing them in person, and move much more towards being able to collect information about patients' conditions asynchronously. And that information can be in many forms. We started with photographs. Now it's kind of any media. We're also starting to support DICOM imaging so that we can pull in kind of diagnostic data. A very wide library of prompts, which again sort of speaks to being able to service most specialties. We're looking at blood results so that we can pull that data in as well. So really kind of collecting as much of the information as we can asynchronously and remotely from patients, family members, school teachers, anyone else who's involved in that person's care. The benefits of that for clinical teams is that instead of being presented with kind of moments in time of seeing a patient perhaps every 3 months on a follow-up schedule, we can instead start to provide clinical teams with real longitudinal visibility of the way that a condition is developing and changing. And underpinning that longitudinal data is a very powerful kind of analytic platform, so that ILA can be doing some of the work to identify patterns and trends that you might be seeing in information submitted from your patients. And the whole point of this really is to get to that kind of fourth stage of enabling clinicians and helping them to make more confident, faster decisions about the next step for a patient, so that we can kind of drive down that time from a referral through to a patient being on an effective treatment plan. You just click on. Thank you. So just to take a quick look, and we'll talk much more about this as we get into Q&A, but just take a quick look at a very simplified version of the pathway that we're talking about today. So really, it's conceptually very simple, and actually, when we started this, I was amazed to find out that surveillance wasn't this already, because kind of having a proactive set of steps along a patient's pathway after discharge from hospital, I think just conceptually makes so much sense to everybody. So the pathway starts at the point of surgery. We would typically be integrated with the EHR or PAS system in a trust, so that we can receive that information and trigger the start of the pathway. We would discharge the patient, and then automatically a personalized timeline for that patient would be created in the platform, which would request that the patient sends us an image of their wound site and completes a wound assessment form at day 7, 14, and 28. Very flexible here, and we can tailor that pathway to suit different clinical specialties. And then really kind of at the simplest level, all that we're aiming to do is move that data to a structured set of clinical reviews, so that we can keep visibility of the patient's recovery post-operatively and flag much more quickly if there's a problem which has been detected, and then we can take the relevant intervention. And then kind of building on that, there's automated steps that we can build into that pathway. For example, if a patient flags something to us, it might be that based on the sort of clinical algorithm that sits in ILA, we can look at that data and we might know that this set of advice should be automatically triggered to the patient, because we know that that's going to be the right next step, and that might be an update to the care plan for the patient to sort of self-care for their wound, as an example. If you just click on one, I'll just show you very quickly how that looks in practice. It's a quite nice example of what we call the timeline view. This one's set up for a post-operative C-section monitoring pathway. So as I said, what we're aiming to move towards is clinicians having a very real-time, longitudinal sense of the way that a patient's condition is developing, or hopefully the recovery process in this case. So that starts with our discharging event, and then all of the set of requests to the patient would be automated from that point on. So the ideal workflow is that the patient just completes and submits this information. As a clinician, you can jump in to any one of your patients, categorized by various sort of risk profiles that we've been able to calculate automatically, and get a very good understanding of that patient's recovery pathway, and then take the relevant intervening action. That's it from me, John.
Fantastic. Thank you, Pete, and thank you, everyone. We are now moving to the Q&A part of the webinar. So if you in the audience have any questions that you would like to ask, please do so in the chat. We've got about half an hour to go through some of those. So ask any that you like, and we can dig into some of these projects in a bit more detail. To kick us off, Melissa, can I ask you about training and engaging frontline staff? So how do you train and engage staff to use these types of technologies in such a high pressure environment like surgical settings? How do you do that?
Thanks, John. So it's a great question. And I think change, as we know, can be quite difficult. One of the things we've found really useful is to start small, use a quality improvement approach, one patient, one time, and learn. And once you start to generate the experience, the outcomes, and you have the information you can share, it becomes a lot easier, although I shouldn't say easy really. It's enables you to discuss with colleagues the benefit, and that's the first thing, is to make sure that they're aware of what the gains are, whether it's reducing time in outpatient clinics or reducing readmissions. So making sure that the story is there. The next thing that we found really useful is just to engage staff with the raising awareness. That really helps to drive compliance with ILA. So if you have a discharging nurse saying, look out for receiving, we always follow up our wounds. So do, expect this text message, that helps. So it's maybe not that you're training the staff to do that, but that you're bringing them into the patient's pathway where they're joining them. And then just in terms of having standard operating procedures for frontline staff who are responding to ILA submissions, making sure that we're taking advantage of the efficiencies that ILA offers, whether it's the automation to get the patients onboarded without having to do, patient by patient, or it's using templates to respond to patients so that it's really light touch and quick. In our experience, I'll use the example in cardiac, where at St. Thomas's, the advanced nurse practitioners respond to all of the ILA submissions. The training was really quick because ILA provided it. And when we offered to take over, the system, like answer their patients for them, they said, no, it's too, it's fantastic to have that follow up. They want to hang on to it. So I think once it's embedded, it really flies.
Fantastic. Thank you, Melissa. And Kenny, can I come to you for two questions, please? Is it possible to share the study that was published in Nature? That would be great to share in the chat. And can I come to you for the first question from Michelle? In this process, who is the clinical review performed by?
At least in our sort of circumstance, it was more in a research context. So we had sort of surgeons reviewing things, but we've done some qualitative work actually, locally, and obviously Melissa's done some fantastic work. She's got it in practice using nurses and that kind of thing. We sort of asked, patients and clinicians and nurses who's the best person to be reviewing this stuff, and the sort of feeling was that nurses are ultimately best placed to have the most experience with wounds, even if it's maybe not always specifically surgical site infection, it's still vastly more experience with what wounds are, and I guess people just wanted the ability to escalate ones that were a bit more complex or a bit, people were unsure of, kind of thing. They wanted the ability to escalate those, as appropriate to, perhaps a doctor or a more senior nurse, TVN or that kind of thing.
Fantastic. Thank you, Kenny. And Ish, can I come to you for the next question from Sarah, please? How did you manage the patient's discharge? Did you have to set up a new team to do that? Was the new team to manage remote patients and the management of patients? Could you take us through how you did that or approached it?
So as Melissa mentioned, change is always difficult. However, I think the way we set this up is that we got the local data that we had, and I presented it at local governance meetings, and it was clear that we really did not have a handle on our infection rate, particularly after patients went home. But also these patients were a little bit lost at sea. So initially there was some challenges in embedding the service, but the way we set the discharge up eventually was, we're very lucky. We have a group of very engaged associate nurse practitioners on the ward. They manage the patients postoperatively with consultant clinical guidance every day. The discharge process was the same. However, integrating it into ILA was the new skills that we had to set up. But within ILA, what we found was that it's a very iterative approach. We designed the parameters that we wanted to ask the patients. We designed at what stages. So we took a photo at day 0 and at day 5 to 7 when they were discharged home. And then we decided, okay, when do we want to interact with the patient? Well, we wanted 14 days, 30 days, 2 months, 4 weeks, and then six weeks, and then other time points after that. We designed the questions together with support from ILA because they had some experience of which questions were most useful from other units that were doing the same process. And then managing the digital side of integrating into the hospital was a challenge, and that does take time for people who are interested in taking such a process on. But there are specific frameworks, and once you jump through each one and take your time doing that, then the team becomes very confident in using it. And once they're confident in using it, the discharge process really doesn't change, but you just use the ILA platform to modulate which questions you actually want to ask the patients. And in fact, the feedback we had from patients has been overwhelming. Even though our population is quite, I wouldn't say elderly, but they're middle-aged to older. They all have, I'd say 90% have mobile devices, and they've all engaged really well with the process. But I think one thing that was questioned was, well, how do we handle those patients who don't have a mobile or don't have that access? Are you discriminating against them? And I think that's just something you have to manage. 90% of patients, over 90%, are very engaged in this, and that gives all of them the benefit that ILA gives them, together with helping us have a platform which enables us to safely share all these images with infection specialists, plastic surgical specialists, and other cardiac surgical colleagues, and other junior staff on the ward. So I think they were the main things that we had to iterate, and also have a specified person actually that was going to deal with all the ILA queries at a specific time of day. And what that did was that instead of being bombarded with telephone calls and ad hoc clinic arrangements, we had one person, one platform every day that dealt with this, and then slowly that has been cascaded amongst the rest of the team. We don't have a big team. We have 8 AMPs, but we have cascaded it amongst everybody, and it works well now.
Fantastic. Thank you, Ish. And that answers our next question as well, which is perfect. Melissa, can I come to you? How does that relate to your organisation?
Yeah, no, just coming in on the inclusivity, because I think everyone's worried about digital exclusion, and I don't think that any sort of service fits every single patient. You're always going to have workarounds, and we can still pick up the phone. But what I love about having digital is, previously we could only provide a follow-up in English. Like, that was it. So now we can have an option where patients select the language where they'd like to complete the form, and we have the responses as well translated, so that we're able still to provide that reassurance, that advice, or if necessary, that referral, which is fantastic. And the other thing is, cultural and family support. There are individuals who would prefer their son or daughter to receive these requests, and so you can nominate the next of kin. So where you might find that there are individuals who won't engage with taking the picture or completing an email or SMS request, you will find plenty of others who maybe were socially disadvantaged, couldn't take the day off work to come to the clinic, or they couldn't get childcare for their child, where you're able to reach them. And I know in our experience, taking the example of maternity, you get new mums sending in at 1, 2, 3 o'clock in the morning, because that's what really provides the service need for them. So I think I'm not saying we shouldn't look at equity of like access and everything else, but I would like to address the point that you can actually increase your reach with digital.
Fantastic. Thank you, Melissa. And the next question, Ish, can I come to you for this one? From the perspective of the patient, how long a patient's able to use Isla for? Who decides and at what point that they no longer need to use? Do patients have a say in that, and how does that work for your service?
Yes, so initially we thought the digital platform was going to be just for those first 6 weeks post-operatively. Since we now submit data nationally, we know that it's actually for the first year that national surveillance is asked for. Although it's not a mandatory requirement, it is definitely a morbidity type which is being more and more closely looked at, and it's actually regarded as good practice for all cardiac surgical units to have that data, so that we will start submitting it to NICOR as a mandatory requirement. So the first year is where we are looking at using a digital platform for, and since we have started using this, we have managed to get the funds together for a surgical site surveillance nurse. And the advantage of having a digital platform was that her hours of work does not necessarily need to be as much as if we did not have this digital platform, because if she did not have it, there'd be multiple phone calls, multiple clinic visits, and many patients missed out of this pathway. But because the patients are taking control, and I'd say 90 to 95% of patients post-operatively are using the platform, her main part of physical work is just trying to reach those 5% by telephone or other means, or formal clinics that 95% doesn't reach, which means that we then have the capacity within that first year to actually really have the granularity of that data and take ownership of it. And because it's all digitized, we know how many people are taking antibiotics post-operatively, which cohort might be having problems, which regional patients are having issues accessing their GP or having any kind of wound care issues. So yes, so it's for the first, just because we have to, it's at the minute, it's for the first year, but I suppose it could be longer than that, but it's probably unnecessary to go longer than that.
Fantastic. Thank you, Ish. Kenny, can I come to you next, please, in terms of speed and accuracy? How has the use of digital tools improved SSI surveillance in terms of accuracy and speed from your point of view?
Yeah, I mean, I suppose things been mentioned before in terms of, often we don't really know what the post-operative SSI rate is, because often the follow-up in the community isn't particularly great. So actually having a sort of accurate impression of what that is, I think is really important from a quality improvement point of view. I suppose in terms of speed, I think that's something reflected by a lot of the patients in these sort of situations where, often facing barriers, getting access to GP or not knowing where to contact or how to contact, and how urgent is it. So actually being able to get, to a certain extent, there's always perhaps a bit of a delay, but ideally sort of near real-time advice on their wound and what they should do with it and that kind of thing, I think is huge for them, and actually be able to get these infections diagnosed earlier, when they're less severe, and hopefully be able to have less morbidity from them. I suppose the other useful thing is probably just that better communication between primary and secondary care. So actually having that, process be a bit more efficient. I know certainly where I am, we don't necessarily have access to community records, apart from very limited access. So actually having a central platform where you have that information, where you can share that easily, you can see, how it would looked in the community versus how it looked, initially in hospital versus, 30 days later and that kind of thing. And that's a huge, benefit to the whole diagnostic process and just the speed of transferring information. So yeah, I think that's it's been fantastic for that process.
Fantastic. Thank you, Kenny. And Pete, can I come to you from a wider perspective across the NHS? Are we early on the journey in terms of moving towards this? And are we moving quickly enough to embrace this approach? What's your view on that?
I think speaking very honestly, no, we're not moving quickly enough at all on this journey. The research is incredibly solid now, and there's a core group of people who really drive this topic forward, and have published many times investigating the impact that you can have by moving to a proactive model from many different angles. So I think the evidence is there that this is something that should be part of standard practice. The challenge is always the implementation and the rate of being able to do that across a complicated system. So no, I think there's a massive opportunity at a national level for the NHS and for other health systems at HC. And I think that it's actually an area which is very overlooked. And I think, I'm not sure why that is. Maybe it's perceived to be academically led or complex, and obviously there is complexity within driving down SSI, but there's also some real low-hanging opportunities, and moving from a passive surveillance model where we just collect a very simple outcome by telephone at 30 days to a proactive model where we can intervene if we see that a patient's becoming more unwell, I think falls into that category of very low-hanging fruit. So there may be people on call. I'd love to see much more of a national level conversation and focus on how we can standardize around a much better model of postoperative care. And that Isla as a technology provider leads the way kind of on for this pathway, but there's many ways to solve this problem, and so I don't even think that technology is the blocker. I think it really is just kind of the rate of adoption of change across the NHS, even when the evidence is really strong.
Fantastic. Thank you, Pete. And Melissa, can I come to you next, please? Similar question to Pete. Have you anything that you'd like to add to that from your perspective? Are we moving quickly enough? Are we early in that journey?
So I think Pete makes the point well, and I know we have a surgeon here who's saying, in my practice this is working fantastic. We have amazing research from Kenny and his team saying, here's the evidence base, you're going to identify the SSI within the first week, more likely to rather, you're going to reduce community visits, you're going to be able to increase patient satisfaction. I do feel part of it was that there wasn't a system to do this well. I do think that we just didn't want to look to the community experience because we didn't know how to without bringing patients back in. So now that we have the technology, we have an opportunity to say, okay, we know we're working in the NHS and change is difficult at the best of times, but what are the wins here? And if I look at the cost of calling a patient at 30 days and that not directly benefiting that patient, it's just a binary outcome, thank you very much, versus the proactive, able to intervene. In cardiac surgery, I think it's the average of £18,000 per patient. There is the argument here that the cost benefit, if you do this and you prevent one of those more serious infections, it really works well. But it's the appetite in a system where people are already working as hard as they can, as fast as they can, and one more thing to do can be a big blocker. So to my mind, we are early on in this journey, but we have to look at workforce solutions as well as leaning into artificial intelligence. And I saw a question early on about, how do you have a dedicated team? And our answer at Guy's and St. Thomas's was to recognize if we wanted to scale this quickly, if we centralized a team, then who could respond to patients,
That would be a far more efficient way of doing things. Reprofiling staff, so you don't need, your higher bands responding to simple submissions. And now we're going to use that model that we developed in Guy's and St. Thomas's to provide a support for a national study. So the Rossini platform started in January, and over the next 5 years, we'll be recruiting 26,000 patients at 100 hospitals. And the hub, the workforce solution, will be using Isla to provide that service. And I would be really interested to learn or to see how that works, because you're taking away then this work of, how do you get the answers to the patients? Well, we're a 7-day service, and if we're all using the same approach, it can be quite light touch.
Fantastic. Thank you, Melissa. And Ish, can I come to you next, please? Either to extend on what Melissa has said, but also picking up on how do you balance innovation with introducing technologies and having high risk areas, busy areas? How do you balance that? And what are some of the challenges you've seen in terms of standardizing data in this area? And how did you overcome those? A couple of questions there.
Yeah, I mean, a cardiac surgical service is always busy. There are many aspects to care that need looking after. I think I'll reflect on what has just been said in that the issue that we historically had where I worked was that everybody was asked to do a little bit in and around wound reviews or surgical site infection. And maybe somebody did it for 2 hours on a Monday and a different person on a Wednesday, etc. through the week. But I think the key thing is to get some ownership of a dedicated individual or group of individuals. And we set up a team involving a surgeon, a surgical site infection nurse, a plastic surgeon, a microbiologist. And you need an inertia within a department to try and help drive this type of change through, but as well as support from industry. And Isla has given us a lot of support in that, in terms of technical help and helping us get through those hurdles, which I really didn't know how to negotiate. The DPIA agreements, the cloud, the network, the IT systems in the hospital. They're the things that I found difficult. I just wanted my patients looked after, and for them to have a way of contacting us, and for any wound issues to be highlighted early. Wound issues will always be there. They're not going to go away, but what we have to do is, like many aspects of medical care, as long as we recognize things early, we have pathways that can be set up to manage these issues so they don't turn into something very significant. I mean, I remember 7 to 8 years ago, I was looking at, by hand, going through the theatre books and looking at the infection rates where we were. And all you need is 10 patients within a year. Those 10 patients will end up, if they end up having a deep sternal wound issue, they'll all end up staying an extra, on average, 30 days in a hospital. They'll all end up going to theatre on average 5 extra times to sort that wound issue out. It involves additional stay, additional specialities. And at that time, if we had an issue, you could end up with an extra 150 hours in theatre from just 10 patients. And what we did was, we just want to stop that tap. We don't want a patient suffering at home with a wound that we don't know what it looks like. They are remote. And it is actually one of the greatest things out of COVID, is that people accepted remote consultation. People all became used to looking at each other online and sharing online material, and the networks that is needed for that to happen safely within the NHS has taken a long time. But I think we are getting there, and the individuals that need to understand that, like Isla and Peter and his team, have also made the effort to understand what it takes within the NHS to enable someone like me to adopt it within our practice, because I don't have that expertise. I don't have that digital expertise, but what I can do is have the team and an interested number of individuals in the hospital to help drive that forward. I'm not sure if I answered your question, but I just gave some thoughts in it.
That was great. Thank you. And Kenny, can I come to you if there's anything you'd like to expand on what we've spoken so far? And also, could you take us through the impact of digital interventions and what have you seen that works in SSI reduction and why do you think they've worked?
Yeah, so I suppose in terms of, I think echoing what a lot of people have said already, kind of thing, I think that the issue isn't technological. The issue isn't, to a certain extent, I think there's some gaps in evidence regarding certain things, kind of thing, but for the most part, there's some really solid evidence to suggest this makes clinical improvement, this should be cost effective, kind of thing. So, it's all more just institutional change and that kind of side of things, which is always the more challenging aspect, and the fact that NHS is overstretched as usual, and doesn't have money for these sort of extra things, even though actually it would actually be cost effective in the longer term. So I think it's kind of just slowly trying to get people to understand that, and hopefully once more and more centres are doing it, it becomes the standard of care, and actually people are saying, this is, why are you not doing this, kind of thing. So hopefully we will see that change coming sooner rather than later for all our patients' benefit. I guess in terms of the most impactful digital interventions in SSI, I don't think there's a huge amount being done in the area apart from this, at least that I've sort of come across. Probably I think, having the ability to collect both sort of patient-reported outcomes as well as images as part of an assessment process in platforms like Isla, I think that is probably one of the single biggest sort of steps forward, in this area of digital health and SSI. As a clinician, being able to actually, collate or correlate symptoms with the appearance of wounds is huge. Otherwise you're kind of just getting that phone call where the patient's reporting things, from their perspective, and obviously they're able to sort of see and give information, but it's maybe not always lining up with what you as a clinician might be looking for. So being able to actually accurately correlate these things together, as a clinician, on top of what the patient's saying, kind of thing, I think is a huge step forward in that whole diagnostic process. There are some emerging technologies, infrared, different forms of light to be able to look at wounds and be able to sort of potentially identify wounds that are at risk of SSI and that kind of thing, which are interesting, and I'm sure will be studied more in the future, but I think are perhaps at the moment a bit unevidenced to kind of really sort of push forward. But there's some great proof of concept stuff that can be done, so I think it's a really interesting area, and they'll sort of keep on emerging in future.
Fantastic. Thank you, Kenny. And Melissa, can I come to you for a more forward-looking question? So what do you think is the biggest opportunity for digital in SSI management over the next 5 years?
I think just to be able to change to that proactive model. So we'd like to step away from the 30-day retrospective, and that's a huge step change for the system. And for me personally, I would love to see, as part of the surveillance program, collecting data on antibiotic use in the community. So I think we know that we're supposed to reduce the consumption by 15%, but we don't actually understand what's happening once the patient leaves hospital, which is something that Ish mentioned as well. Just having that information is really powerful, and I think that it's going to be. Yeah, for me, those are the kind of two key areas. How can we improve patient care directly using this approach, which is very different to the existing surveillance program? And secondly, how can we enhance what we know in terms of therapies, and how we can sort of help drive an antibiotic stewardship program with our surveillance program, very light touch, without having to spend lots of time. Patients can provide that information.
Fantastic. Thank you, Melissa. And Ish, can I come to you next, please, to pick up on Kenny's point about organizational change and culture? What changes in organizational culture or mindset are needed to fully adopt digital solutions? What's your perspective on what's needed to do that, please?
Efficiency within the NHS is a language that everybody understands. I think to change a culture and adopt a digital platform, those who understand the benefits, and I'm one of those individuals that now is starting to understand those benefits, to explain it to others who maybe not that familiar, you got to get used to the talking their language, and that is readmission. It's about clinic appointments. It's about reducing the efficiencies within the systems that we have, helping patients take ownership, empowering patients in their own decision making. Patients want to be involved, and there are many automations, I think that was referred to earlier, that can take place. This I think listening to Ken and his research and involvement of big data and the use of AI systems, I can really see how recognition of photographic evidence, integrating that into clinical parameters, much of this can be automated, and that will reduce hospital admissions. It will reduce hospital clinic episodes. Patients will be able to manage in the community. People will not have to travel in. And then we can concentrate our efforts on those that really need hospital management of their wounds. I think that is what I have learned, is that to engage and to change culture, I have had to understand the language that the business managers use within the NHS. All the clinicians want the same thing, the patients want the same thing, the nursing staff want the same thing, but it's enabling the resources that we have. And I accept we haven't got unlimited resources, so we've got to do the right thing with whatever resources we have. And much of the time it's helping other people understand the impact and utility of these digital platforms in whatever areas of life you're working in, but particularly within the NHS. And I think it's something that hasn't been done enough really over the last few years. And wound management is one of those areas that I've been involved in, and I can definitely see the gains made in that area.
Great, thank you for that. And we have 2 minutes to go, so could I ask you to provide a key takeaway for the audience? What would you like them to go away with? Kenny, can I come to you first in terms of a key takeaway, please?
I suppose digital health interventions like this, as has been said, I think they are fantastic opportunities to increase efficiency through automation. I think we're probably starting to maybe use it, but I think we're maybe far off using it for taking over wholly diagnosis. And so I think we just need to be looking forward and innovative with it, but then also just be considering acceptability and safety and making sure we're making it work for everyone in the community.
Fantastic, thank you. And Pete, can I come to you for a takeaway, please?
Yeah, thanks, John. If you don't mind, I might just use my 30 seconds to talk on integration, because there's quite a few questions on that.
Sure.
So just to address those, yeah, Isla can both sit standalone and is integrated with things like the PDS. So rather than sort of fully standalone, you can use Isla as a very manual platform if you like to. Much better than that is to integrate directly with the EPR or the PAS system. And so from our side, we're very flexible on how we do that. We have H7 and FHIR interfaces, so that enables connections into things like EMEA, System 1, and Track Care. I know there's a team up in Scotland, so sort of Vision as well would be possible through that mechanism. CERN is a very sophisticated integration. Epic's a little slower, but along the way. So yeah, just say if you're thinking about this, we would recommend as early as possible taking this to the kind of IT teams, try and get buy-in to doing this in an integrated way, because certainly it sets us up for a much more scalable, easy to use, user-friendly experience.
Fantastic. Melissa, can I come to you, please?
Thank you. So for me, SSI surveillance is such an important driver for surgical wound management. It really helps to identify not just outbreaks, but, you know, if interventions are working or not working. And I think that the reality is with shorter hospital stays, people are leaving, we need a way of following this up so we have that important information to help drive improvement. So yeah, I just fly the flag for surveillance and digital being a really light way to do it.
Fantastic, thank you. Anish, can I come to you, please?
There's so many take homes and so many messages, but I think if there's one or two, I suggest have a dedicated team, have dedicated individuals. If you're interested in taking on a platform such as digital, then involve IT teams early. It is a little bit uncomfortable to start with, but I would stick with it, because the benefits, once you've got through that initial unfamiliarity, everybody realizes the benefits, the efficiency in time, the reliability of the data that you get, the empowerment of patients, and the patient feedback is all overwhelmingly good.
Fantastic, thank you. And I'll look to close the webinar here. Apologies, we've run over by a minute. I'm sorry about that, but it's been a fantastic session. And thank you to the panel for joining us. It's been great to hear about your work and the impact of that. So I really enjoyed the webinar today. So thank you for taking the time to join us. And thank you in the audience. Hope you've enjoyed it too. The session has been recorded. There'll be a write-up as well, so you can read or watch it back. But yeah, thank you everyone for joining today, and have a nice day. Bye, everyone. Thanks a lot.
Thank you.
Thanks,
Bye.
John. Bye.